the common things are common. And unfortunately, whilst headaches are incredibly common, the lifetime prevalence is more than 90%, and at least 40 or 50% of people will have headaches in any given year. The vast majority of headaches are benign, and work that David Kernick did well over a decade ago now showed that the likelihood that somebody comes to see their GP with headaches has a brain tumor is extremely low. And if the GP can confidently make a diagnosis, a primary headache diagnosis, tension type headache or migraine, then the chances are even lower than that. Headache consultations are very common in general practice, and they're very common in emergency departments, A&E and AMU. But it's important to set this in context and to remember that the vast majority of people who present to primary and secondary care will have primary headache disorders, tension headaches, migraines, cluster headache, and some of the rarer headaches that we're going to hear about over the course of the year. And that actually, even in emergency departments, even in A&E, serious secondary headaches account for a very small percentage. And of course, we're going to hear about red flags later on. We're going to hear about the sort of things that, might give us cause for thought or ring alarm bells. But again, it's important to set this all in context, that headache disorders can be very debilitating. They can have a huge effect on people's lives, but they are very rarely the sign of serious secondary underlying disease. So I think it's really important, and this is all just, I mean, I'm not going to sort of teach you all to sort of suck eggs and take histories, but I am going to sort of just suggest that really, it's important as that patient sort of, comes in, you should just be asking yourself, why is this patient presenting at this point and here and now? And the sort of things that will bring patients to see you with headaches are new types of pain. So you might see people who've got sudden sort of severe pains that come on, or persistent pains that are continuous. You may have people who come with headaches and other signs and symptoms. You may have somebody that comes with what they experience as a typical pain, but unusually severe, or it's not responding to the treatments. And I think, in primary care, we know that the vast majority of people with headaches manage their own problems. And they only come to us when they can't manage with over-the-counter medication with the advice of their family, their friends, their pharmacist. And it's also useful just to sort of, at some point, ask the patient, what are you hoping to get out of this consultation? Ask them the question, why are you here? What are you hoping that I can help you with? So like any other sort of good history, it is always helpful to start with an open question. How can I help you? Or tell me about your headaches. And then it's really important to shut up and try not to interrupt the patient, to let them talk for a certain length of time about their problem. And of course, how long you let them go on for will of course depend on the environment that you're in and how long you have. So, if you are, fortunate enough to be seeing a patient in a private medical consultation and you've got 45 minutes, you can let them rabbit on for ages. Whereas obviously, if you're in a GP consultation and you've got 5 minutes or 7.5 minutes, or if you're in a busy A&E department, you will have to, fall short on how long people can talk for. But it's really important to let people talk initially. It establishes rapport. It begins your therapeutic relationship with the patient. And it's really important that patients feel that they've been heard. It's very sad, but very, very frequently hear patients who come to the end of a consultation and say, look, I think that's the first time anybody's actually listened to me talk about their headaches. And William Osler, encouraged you to listen to the patient, because quite often he is telling you the diagnosis. And in headache medicine, almost always the patient is telling you the diagnosis. Headache diagnosis is an awful lot about pattern recognition. And right from the very start, I would encourage you to consider the pattern of the headaches. Are these episodic attacks, or are these more persistent or chronic headaches? If they're episodic, how long are the attacks? How long do the headaches last? Are they seconds? Are they minutes? Are they hours or days? How often are they happening? Are there patterns to it? Are they coming in bouts every few months and then going away again? Or are they coming at a certain time of the month? Or are there specific triggers and specific things that bring them on? If you're seeing somebody with persistent or chronic headaches, it's really important to find out how it started. Is it a new daily persistent headache, a headache that starts one day and just hasn't gone away? Or has it transformed from an episodic headache into a chronic one, as is so typical with migraine in particular? And if it's there all the time, is it constantly there at a single level, or is there a background level with flares of pain? Is there a variation to it? Does it vary by the course of the day? Does it get worse as the day goes on, or better as the day goes on? And are there other sort of obvious things that cause that constant pain to vary? Are people better when they lie down or stand up? Those sort of things. And alongside this, of course, like any other sort of pain history, we want to get an idea of the character of the pain. Yes, where is it? Is it unilateral? Is it bilateral? Is it at the front or is it at the back? You want to ask people about their worst headache, and there's really good evidence, for example, that people who have migraine may have a variety of headaches, some of which are full-blown migraines, some of which are less severe, and some of which are even just tension-type headaches. But they're all migraine biology. They'll all respond to migraine treatment. People can have more than one type of headache, and what you're looking for is to try and understand what is the debilitating headache, what is that headache that's brought you to see. I think in any headache history, because migraine is so common, it is so likely to be the cause of the patient coming to see you, that you should always ask about migraine features. Do people experience nausea? Do they find that normal levels of light make the pain worse, which is what photophobia is? Is it exacerbated by movement or mild exertion? And it's always worth a few questions about autonomic features. Do they get redness of the eye, teary, nasal congestion? What do they do? How do headaches make them feel? People with migraine will want to go and lie in a dark room, be still, be quiet, not move too much, because that will make the pain worse. People with cluster headache and other trigeminal autonomic confounders will be agitated. These are the people that will be restless. They'll pace, they'll rock, they'll literally bang their head against a brick wall. You should ask people what they do when they have a headache, and it's really important to get a very clear idea of what painkillers they take, how they take them, and where they get them from. And don't just sort of assume that the prescription that you've given them or someone else has given them is all that they're actually taking. You need to delve into that a little bit. Previous preventive medications and interventions, whether they've been helpful or unhelpful, and non-pharmacological measures are all useful to know about. And then you do, of course, need a little bit of background history. And of course, again, how much of this you've got will depend on where you are, how much, whether you know the patient. You may know all about their past medical history. You may have their drug history in front of you, or you may not. A family history of particularly of migraine or other headaches is always useful. And it's important to ask questions about how headaches impact upon people's occupations, the effect of alcohol, and very much about things that might be driving headaches forward, particularly sort of chronic headaches. So things like caffeine, sleep disturbances, and the presence of depression, anxiety. Again, these can all exacerbate an underlying tendency to headaches and make things worse. So once you've got that information, and it doesn't take a long time to get it together, and as I say, you have to tailor this to the situation that you find yourself in. But really what you're looking for is that two sides of it, the pattern and the character. And in many cases, that will be enough for you to get a working diagnosis. This is episodic migraine, this is chronic migraine, this is cluster headache. Episodic headaches are most likely to be primary headaches, but there are exceptions. And similarly, chronic headaches are still most likely to be benign. They're most likely to be chronic migraine or headaches driven by medication overuse. But there will, of course, be serious secondary headaches. And those will usually present as a headache that starts one day and doesn't go away. And you need to listen and look carefully for red flags that Alok's going to talk about after me, and have a low threshold for referral or investigation of people who have that pattern of headaches. Beware the person who has never had headaches before, who suddenly starts to get them one day and they don't go away. These are the people who might cause trouble. Very briefly, having given you a sort of a brief sort of overview and said, well, look, you want to have a sort of framework, and you want to kind of assume that people are maybe, you're going to see lots of migraine, and that's going to get you quickly to an answer. There are pitfalls in that, and it's just important to have this in the back of your mind. And I'm sure many of you will be familiar with the work of Daniel Kahneman, the idea that we have kind of what Kahneman calls type 1 and type 2 processes. The type 1 process is a fast, reflexive, very much based on our experience and our preconceptions. And the type 2 process is a much slower, much more analytical. And of course, we rely in medicine hugely on type 1 reading, the sort of rule of thumb, the pattern recognition, the sort of quickly ruling out worst case scenarios. And we do that because we're busy and we don't have a lot of time. And these ways of looking at things are often effective, and it usually comes up with good decisions. But it is very prone to cognitive biases, and those can sometimes be really problematic. And the sort of situations that promote those cognitive biases will be very familiar to all of us who work with the NHS, in headache clinics and primary care and any departments. Time pressure, high patient volumes, distractions, interruptions, the phone going all the time, fatigue and sleep deprivation, and our personal stresses. Uncooperative or difficult patients or complex illnesses, and for a lot of my otherwise very competent neurological colleagues, headache patients are their hearts in patients. They really don't enjoy trying to work with them to come up with answers, and therefore they will tend to jump to conclusions and often miss things that they shouldn't do. So the sort of things that you can do, I'll just give you just 2-3 very quick examples. Overconfidence is maybe not so much of an issue with ours, but it's kind of interesting and kind of fun. The whole idea of overconfidence is this thing called the Dunning-Kruger effect. So just, as an idea, what percentage of people say that they're in the top 30% of drivers? What do you think? Well, I happen to know I'm not, but I know an awful lot of people who think they are. And actually, when you ask people, it's about 80% of people who think they're in the top 30%. What percentage of Harvard Business School MBAs say that they are better looking than their classmates? Well, of course, again, that's a pretty high amount as well. That's about 80%. And what percentage of doctors were definite in diagnosing cyanosis in patients who actually turned out to have normal oxygen levels? And even that was about a quarter. So we often quite confident in our own abilities, even in certain situations where we might not necessarily be. And of course, there are ways of dealing with that, get other opinions, generate the alternatives, use checklists, and that can be helpful even in sort of headache, assessment. I've mentioned the importance of actually having a framework and that understanding that things like migraine in particular are very common, and so on. And but of course, that can introduce a bias, and the way problems come in can frame things that will force you in a particular way. So sometimes you have to ask yourself, well, what am I missing? Am I seeing things in a sort of different way? And then this one, I think, again, is important for those of us. And the more headache patients we see, and the more we think we see migraine in particular everywhere, we may start suffering from confirmatory bias, which is basically looking for things that will confirm our preconception of what we're going to find. So we may start asking questions that are going to search for migraine or a particular preconceived idea as a diagnosis, and we'll give more weight to things that sort of support that than things that might take us in a different direction, and we'll remember that type of information better. So again, it's very important to just take a step back, think about other diagnoses, think about those things that don't quite fit with what we thought we were looking at. And these are the sort of questions that, again, one could just ask oneself, could this be anything else? Is there anything I can't explain or doesn't fit? How does this patient make me feel? Maybe the patient does have more than one problem. Do I need help to make a diagnosis? And as this New Yorker cartoon says, it sort of makes you stop and think. And again, stopping and thinking is something that we should all do. And we don't have a lot of time to stop and think, but we should all be doing it a little bit more. And again, even with a headache diagnosis, we should always just have that few seconds just to stop, think, does this fit? Is there anything that doesn't feel right? So just to conclude, it's really important to understand what headaches you're likely to encounter in primary and secondary care. And migraine and more migraine really is by far the commonest reason for people to seek help with migraines in both primary and secondary care. But it's important to be aware of that framing bias and that confirmatory bias and be alert to things that don't fit. I've already said to be wary of that patient with a new daily persistent headache, because there are dragons, okay? There are the people that you need to pick up, because there may be the people with tumors or with other serious secondary pathology. It's really important, and I would encourage you all to try to make a diagnosis, okay? Chronic daily headache is a syndrome. It's not a diagnosis. Headache not otherwise specified is not a diagnosis. It's not always possible, but in a lot of cases it is, and it's really important. Even if it's only a working diagnosis or a hypothesis, it gives you a place to start. It gives you a way to explain things to the patient and to take that diagnostic and therapeutic journey forward. A well-taken headache history, even one that you've taken in 3 or 4 minutes, is a joy, and it will start your therapeutic journey with the patient off in the right direction. And I'd encourage you all to practice and enjoy the art of taking a history.
Thank you very much, Mark. That was very good. And thanks for your leadership to the BASH, because in your leadership, NICE has changed their decision of the adenomab, and not even changed that, but they actually allowed us to use it in episodic migraine as well. So lovely leadership. And we'll take the questions at the end. Let me ask our second speaker, who's Dr. Alok Tyagi. Alok is a consultant neurologist and past chairman of the British Association for the Study of Headache. Alok works in Glasgow, and he's going to talk about the red flags and what red flags you should be really concerned of if you don't want to miss the secondary headache. So Alok, your turn.
Great. Well, thanks very much, Faiz. Thanks, Mark. That was a great talk as always. And thanks to Bash and Faiz, you specifically for asking me to speak at the first webinar today. I hope you can all hear me clearly. So I'm going to share my screen now, and hopefully you should be able to see all of my slides. So let's go. Okay. Right. Okay, can you see? Okay, sorry. There you go. Right, can you see my slides now? Yeah.
That's fine, thanks.
Okay, great, thank you. So yeah, my talk is on red flags in headache, and as Mark has already alluded to, headache is common. Regardless of what you do in medicine, whether you work in primary care, whether you are in the accident emergency department or in internal medicine, or of course, if you're a neurologist, and dare I say, even if you're a neurosurgeon, you are going to see patients with headaches, and because it is such a common condition. And if you look at statistics and data from the United Kingdom, about 4.4 of all general practice consultations are for patients who have headache as their primary symptom. And we in secondary care, I work in a hospital in Glasgow in Scotland, and we would see only a fraction of really what comes into primary care, because the vast majority are managed very well in primary care and don't really need to be referred on. If you flip that and you look at the proportion of the patients who attend with headache disorders to hospital, if you look at the accident emergency, just under 2% of all admissions are where headache is the primary problem. And if you look at neurology clinics, we in neurology are now sort of delving into subspecialties all the time and discovering new therapeutics. But about a third of what comes into our clinics are patients with headaches. And as Mark has already alluded to, the vast majority of them are primary headaches. And it's interesting, I don't know what the curriculum is for other parts of the world, but certainly up until a few years ago, medical students would spend maybe a couple of hours in their entire curriculum studying headache disorders, and their focus would be to look for secondary headaches, which form a really small proportion of all headache disorders. And certainly that's the case in primary care. And obviously one reads these, as Mark had shown in his talk as well, you get this media attention on some of these instances. And also it depends on where you are sitting in the healthcare system. If you're a neurosurgeon, every headache comes that you see, it's a subarachnoid hemorrhage unless excluded. Whereas if you're in primary care, the vast majority, and of course in neurology as well, vast majority of primary headache disorders. So one view would be, well, if you see patients with headaches, why do you need to bother with red flags? You just scan everybody, okay? The problem with that, of course, is that it's not a single scan. If what do? You do a CT scan, that may be good to pick up, post-traumatic extradural or subdural hematomas. You could do an MRI, which might look up at the posterior fossa reasonably well, but won't look at the arteries and the veins. Do you do a MR venogram, or do you start to do all of these scans in every single patient who has a headache disorder? Absolutely not, because apart from the fact that it's going to have a major impact on the healthcare resources, you're going to be picking up incidental abnormalities. And we looked at this about 10 plus years ago in Glasgow and looked at primary care referrals for CT scans. And our numbers were very similar to what is described in the literature, in that between 6.5 to about 13.5% of scans pick up entirely incidental changes. And the vast majority of these are non-specific, few white matter, non-specific white matter changes, or perhaps a bit of sinusitis. But you do pick up significant abnormalities, which are incidental in the main to the headache syndrome. But nevertheless, they increase the individual patient's anxiety about their health. And of course, you then need to monitor these, even though none of these significant abnormalities in the main require any specific treatment. So what you do is exactly as Mark said, is that what we all do in clinical practice, is that you take a good headache history, that you spend your time speaking to the patient and letting the patient tell their story, and also perhaps asking some leading questions and directed questions. So, and this is perhaps, as I work in a hospital, this is perhaps, these questions are maybe a little bit focused towards people who attend the secondary care, but could also be directed into primary care. But perhaps this slide is looking at questions that you're going to ask a patient for that particular headache episode. So what is important is to know, what were they doing when the headache came on? And if you get a history, well, that they were engaging in intercourse or sexual intercourse or physical exertion, or they were at the gym and lifting heavy weights, and if the headache came on at that time, well, you need to address that, and you need to look into that a little bit more in detail to ensure that there's no underlying secondary cause. Now, I know that you have in the current webinar series, there's an entire day which is devoted to looking at secondary headache. So I'm not going to dwell into each of these individual ones, although we'll have a couple of slides later on. The second question you ask is, well, how long did the headache take to reach its peak? Now, that is one of the most important questions that you ask when you're taking a headache history, because of the concept of thunderclap headache. We'll talk about that. The third is, how long did the headache last for? If you have somebody who has a sudden onset headache when they were exerting, which reached its peak within a matter of minutes, but it lasted for about 15 minutes and resolved, your aim of investigating these patients would perhaps be a little bit less as compared to somebody who had an acute onset headache which reached its peak and that then persisted for the rest of the day. It's important to know what is the site of the pain. If somebody has a unilateral, frontal or retroorbital headache, the likelihood of that being due to a secondary cause is perhaps somewhat less as compared to a generalized or an occipital headache, although not always so. The intensity of pain is a little bit debatable, because when you see patients who've got migraines or cluster headaches, they tend to be the ones who are most severely affected, in the clinical sense. The question about change in the headache with posture is hugely important, because that may suggest that we are looking at a CSF dynamic problem. And then, of course, is the issue about, well, have you had a similar headache before? So if you have somebody who comes in with an acute onset headache, which they've never had in the past, your investigational profile is going to be different as compared to someone who's having repeated severe headaches, which are coming on very rapidly over the last couple of weeks, as compared to someone who perhaps had a very similar headache maybe 6 or 8 months ago. So it's hugely important to dwell on these. You need to ask questions which may be related to other features, and Mark has talked about migrainous and cluster headache related features. From my perspective and from my talk, I suppose what we need to focus on is looking for additional focal neurological signs or symptoms which you are not going to attribute to aura, which we'll talk about later. You also need to look at recent history of trauma, you need to look at immune suppression, a history of malignancy, because all of these, if present, would increase the possibility that we are looking at a headache disorder which is not primary in origin, which means that there is some other underlying process that's triggering the headache. It's also important in a headache history. It's always very important to get a medication history, not just to be able to identify the elephant in the room, which medication overuse headache is, but also because if there's somebody who's taking an anticoagulant and they develop a new onset headache, you know that your direction is going to be to look for any hemorrhagic consequence of that. Drug history, illicit substance history is also very important to take. A brief examination, clearly systemic signs are important to identify, particularly in the secondary care setting, but also, of course, in primary care. So if there is associated fever or high blood pressure, or of course, if the consciousness level is affected, then that's a big marker for a secondary headache. Now, a lot of our medical colleagues, would perhaps shy away from saying that, well, a detailed neurological examination is really going to take a lot of time. Let's just go ahead and do imaging studies. But if you do a brief fundus examination, looking at the pupils, extraocular movements, coordination, perhaps just with the finger nose test, and look at the gait assessment, that doesn't take longer than 2 or 3 minutes. And our colleague Giles Elrington has got a very nice video which covers all of these examinations in a fairly rapid time. So this would be a suggested examination when you're assessing a patient who presents to you with headaches. So if you look at the presentation to A&E, and I've tried to summarize the majority of what we see, and as Mark said, even in this setting, the vast proportion of patients who attend have a primary headache disorder, such as migraine or cluster headache. However, the 3 scenarios where you see attendances to A&E with headache disorders with a potential underlying secondary cause are these. First is, of course, an infective cause. If there is a headache in association with a fever or neck stiffness or of course, a skin rash or a particular rash, then that requires emergency intervention. Usually, you would perhaps forego and do a lumbar puncture to confirm a diagnosis of meningitis. And if you do see a rash, you will, of course, treat that while you're waiting for the CSF to be done. We do, as neurologists, get asked to see patients with violent encephalitis because of the occurrence of seizures. And again, in this scenario, investigations are hugely important to confirm the diagnosis. And then, of course, we come to thunderclap headache, which the term was actually just coined in the 1980s, so not that long ago. And as we talked about in the previous slide, it's a headache that reaches its peak within a matter of minutes. And I think we debated about this when we were doing the SIGN guidelines more than a decade ago. And I think any headache that reaches its peak within 5 minutes should be assessed and investigated as a thunderclap headache. And depending on which part of the world you live in, often the description is that you've been hit at the back of the head with a cricket bat or a baseball bat or a hockey stick. And the reason why we think thunderclap headache and assessment is important is because about a third of these patients have a potentially life-threatening or disabling neurological condition, which is that they are secondary in nature. And the most important one, of course, is subarachnoid hemorrhage. And the vast majority of patients who have this have a headache, and about a quarter of them, up to a quarter of them, have a thunderclap headache. And the reason why subarachnoid hemorrhage is, of course, hugely important to recognize is because of the significant morbidity and mortality associated with it. But bear in mind that subarachnoid hemorrhage is not the only cause of thunderclap headache, and you've got a variety of other causes, which I'm sure my colleagues would look at in more detail at the next webinar. But just to talk about things like arterial dissections, venous sinus thrombosis, etc., they are important causes of thunderclap headache as well, usually associated with some other focal neurology, but not always so. Then, of course, is the issue of raised intracranial pressure. And I use this quite often in my clinical practice to try and explain to patients why their headache is not a headache suggestive of a secondary cause, because you need to have a progressive headache. So it has to be happening every day. If someone has a headache once a month, it's not because of an underlying secondary cause. It's almost certainly a primary headache disorder. The second important aspect is precipitation or significant aggravation of the headache with a Valsalva maneuver, such as intercourse or lifting or coughing, straining. Now remember, any headache disorder, migraine will get worse if you do Valsalva maneuver. However, it wouldn't get precipitated by it. So it's the precipitation or significant aggravation, which is the important factor here. And of course, we all know the importance of eye examination to try and pick up papilledema, which is a marker or a sign of raised intracranial pressure. And this is David Kernick's seminal work, as Mark said, more than a decade ago, in which they looked at, well, what are the red flags? So what are the symptoms and signs when you see patients in primary care that would make you think that we are looking at a tumor? And they looked at probability. So the probability that you're picking up a tumor, and more than 1% of probability, would be if the patient has either got on examination any focal neurological sign, or they have papilledema, or if they have significant alteration in their cognitive state. The presence of a new seizure, a new onset cluster headache, and a history of cancer are all pointers that suggest to you that if you see someone with a new onset headache and they have any of these features, you need to be alerted to the fact that this may be because of an underlying brain tumor. So these are the well-recognized red flags which increase the probability of picking up a tumor. What about NICE, which is the National Institute for Health and Care Excellence in the UK? And they have an exhaustive list of what features suggest a serious cause of headache. And we've talked about the thunderclap headache. They also brief about new onset headache in a person above the age of 50. Now remember, this is new onset headache or a different headache, not somebody who's had migraines all their life and that has increased, but a headache which is new. And of course, in this group, the occurrence of temporal arteritis or giant cell arteritis is a big type of secondary headache. We've also touched upon progressive or persistent headache. We've talked about some of the associated features, examination abnormalities, new onset neurological deficit. Now remember, aura is a fairly common, about 30% of migraineurs get an aura. Now we're not talking about, when we talk about new onset focal deficit, we're not talking about what is a typical visual or sensory aura. We are talking about other abnormalities or an aura which is atypical, the duration is greater or involves motor weakness. You need to look at the precipitating events, the preceding recent history of head trauma or a history of immunocompromised state. And all of these factors are hugely important, which point you towards a secondary cause for the headache. And I think Mark touched on this. I think using the temporal pattern of headache is really, really important when you're taking a headache history. We've talked a lot about the sudden onset thunderclap headache and the higher probability of a secondary cause. And we've also touched on the recent onset and progressive headache that is present on an everyday basis. And the likelihood of that being because of a secondary cause is certainly much higher than if somebody has a recurrent episodic headache, which is almost always primary in origin, or if somebody has what's termed as a chronic headache. Now remember, chronic headache is not a diagnosis, it is an umbrella term, and that it involves a number of other primary headache disorders. So a chronic headache is more likely due to a primary headache disorder than a secondary one. But what does all that mean? If you try and put it all together, and this is taken from great work done about 15 years ago in Sheffield, where they looked at roughly around 800 patients attending the A&E. So what are the odds ratio? What are the features when you see somebody with a headache disorder which tell you that, look, I need to investigate this further because these are red flags and the likelihood of an underlying secondary cause is high. And these are primarily four. One is, and the most important and the most, the feature which is most likely to be associated with the secondary cause is associated focal neurological deficit on examination, or a new deficit, which is not like an aura, a new deficit which is present on history taking. The second is age. Patients who present with a new onset or a first episode of headache or a different headache above the age of 50, the likelihood of picking up an underlying pathology, secondary pathology, is high. The third is a sudden thunderclap or sudden onset headache. And lastly is associated systemic features. And this is a variable odds ratio depending on what systemic feature you're looking at, whether it is a temperature or a high blood pressure, or you're looking at meningism. So depending on that, what associated systemic feature you're seeing, the odds ratio is variable. But if you summarize all of the red flags, these are the 4 which are important for you to pick up in when you're taking a headache history. And if you conclude, if you like these mnemonics, you could remember Snoop. S stands for systemic symptoms, fever, weight loss, or secondary risk factors such as systemic cancer, immunocompromised state. N stands for neurological symptoms. Now remember, not the aura, but neurological symptoms or signs on examination. Onset, I think we've dwelled on quite a bit. Thunderclap, sudden onset. Older patient, that's the second O, and you need to consider the possibility of a secondary headache. And of course, we've talked also about the previous headache history, whether it's the first time this type of headache has presented. So the takeaway would be Snoop. So remember that these are the red flags when you're assessing patients with headaches. Thank you. I'll stop there.
Thank you, Alok. That was good. Please keep sending questions. I'm monitoring the questions at the moment, and we would take answer all the questions at the end. So Alok, if you could stop sharing your screen. Wonderful. So a couple of things. Some people have told me that they can't hear. We are also live on Facebook, so you can actually join through the Facebook. It's a live streaming going on. And secondly, we are recording it. I haven't worked out how we can send you a recording, but certainly it would be available on the BASH website once we have worked out how to do it. It's the first webinar I'm hosting, so do apologize. I don't have many information about that. So let's move on, and we'll get our third speaker, Dr. David Kernick. You've already heard about his paper of 2008, where all the BASH people were involved. David Kernick works in Exeter, and he's a general practitioner with interest in headache disorder. He's a champion of the Royal College of General Practitioner on headache disorders. He's also leading the subspecialist group on primary care in the British Association for the Study of Headache. And he is a fellow of NICE, although he's a NICE fella, but he's also a fellow of NICE. He's going to talk about 10-minute consultation in the primary care. My wife is a GP, and she says it's very difficult. For neurologists, 10-minute consultation, literally impossible. So you see how he does that in 10 minutes. David.
Okay, thank you, Fayez. I hope you can all hear and see me okay. I want to offer a perspective from the swampy lowlands of primary care. And although cognitive biases are really important, GPs deal in prior probabilities. And I want to just talk you very briefly how I would tackle these 2 cases. A simple case, a 3-week problematic headache with no clear pattern. You don't know what the diagnosis is. And then the second case is a complex case. This is the sort of case we'd see on a Friday afternoon. You're already running late. You have to get home to pick the kids up, and you think, God, what on earth am I going to do here? These are sort of cases we see in our headache clinic. I run an intermediate care headache clinic, and you can really turn people's lives around. We have the luxury of 45 minutes, and these are really rewarding problems and challenges. And I want to talk you through some pointers as how you might manage both these cases in 10 minutes. I think it's important just to have a little think about how we see medical presentations. This is after the work of Balint. They can be recognized in terms of the disease. This is the pathophysiology. This is the migraine. But headache sits within a complex called the illness. This is the complex biopsychosocial perspective. And Marinka reminds us that it is here that we negotiate the interface between the potential of bioscience and the predicament of the individual. And I think that's why headache really does sit in primary care, because headache never comes alone. It always sits within the context of a complex illness. And then finally, there's the sickness, how society feels the person with a problem should be performing, what he should do, and how they see the illness. And in fact, from the headache perspective, headache is very stigmatized. And I think it's also important just to tease out some differences between secondary care and primary care. And I very much like this quote, although it takes a little bit of unpacking. So in secondary care, the role of the specialist is to reduce uncertainty, to explore possibility, and to marginalize error. Whereas in general practice, We need to accept uncertainty, explore probability, and to marginalize danger. And I think what he's saying here is that in secondary care, they have to explore the whole range of things and they can't get it wrong. Whereas in primary care, we are paid to accept risk. We take risk while a diagnosis emerges, and we diagnose what is common. Common things are common, although we must always be on the lookout for danger signs. So what do people with headache who see their GP actually have? Here's a range of suggestions from a number of different studies. I just want to pick up on this concept of tension type headache. I think I've diagnosed tension type headache about 5 times in my life. For me, most tension type headache that is bad enough to come and see their GP, if you look hard enough, you will find migrainous elements. So most of that tension type headache will be migraine in my book. So I would confidently say that well over 90% of what GPs see is migraine. And I also think that we're actually not algorithmic. We are heuristic creatures, bearing in mind our cognitive biases, of course, but I think this is a good rule of thumb to take away in general practice. If they're under 50 and they come and see you, ask yourself, why is this not migraine? If they're over 50, ask yourself, why is this not temporal arthritis? And only look inside the brain if there's a good reason to do so. So I think that's not a bad starting point. So let's get into these cases. Here's our first case, a simple case, a new undiagnosed headache. And your management approach here is to allow a pattern to emerge. It's a fit 28-year-old female, 3-week history with no clear pattern. So Mark's alluded to the important points of the history. Here are some important points for me in primary care. I'm always asked after a family history, because I'm always looking for a history of migraine in the family. Does anyone in the family have problematic headache? They might not even recognize it as migraine. If they do, there's certainly a very good chance you're actually looking at migraine. And again, Mark alluded to this interesting question, how many headaches do you recognize? I'll pick that up again when we look at the complex case. What you do is a really important question. Migraineurs will want to lie down in a quiet, dark room. Cluster headache will be agitated, they'll pace the room. I think it's really important to tease out the impact upon people's lives that makes them realize that you're actually interested in them. Menstrual relationship is always useful. About 7 to 9% of females will get pure menstrual migraine. That offers other alternatives for management. But I think when they come up, if they have an estrogen sensitivity, when they come up to perimenopausal time, their migraine is likely to get worse and you need to be aware of that. And I'm always interested in their medical history because with migraine, which is our default diagnosis, we're on the lookout for comorbidities, and it's really important to recognize these and treat as appropriate. Anxiety and depression are really important, 3 to 5 times more common in people with migraine. Then these other painful conditions, probably modulatory problems of the ascending pain networks, irritable bowel syndrome, fibromyalgia, and restless legs are quite common. If they have restless legs, they're not going to sleep. That'll make the migraine worse. And there are a number of other comorbidities, of which asthma and epilepsy are amongst the most common. But it's anxiety and depression we need to focus on, and everyone should be asked about those 2 problems. So case 1, what's going to happen at the presentation? We're going to take a history, and examination minimum is blood pressure and fundoscopy. And I think that's absolutely fine. I don't think you need to go any further than that on the first presentation for your 10-minute consultation. Let me just say something very briefly about examination, and don't quote me on this because I'll probably get struck off the list, but virtually all of headache diagnosis is on history. I cannot remember a case in my career where I've changed my management plan on the basis of examination. I'm not saying that never happens. It's probably a reflection of my poor examination skills. But I think for me, in reality, I examine people to keep myself out the law courts. People like to have their tendons tapped and their eyes looked into. Clearly, fundoscopy is really important. And diagnosis is of lesser importance. That's not a good teaching point, but in reality, it's all on history. So once you've taken that history, once you've done your blood pressure and your fundoscopy, you'll be ready to press 1 of 3 buttons. A red button, do something right now, an orange button, do something soon within a couple of weeks, or a green button, manage the headache or allow a pattern to emerge. So what we're going to press the red button for, well, this has been alluded to with Alok before. He's looking at thunderclap headache. We're looking at, I think anyone with a new headache over 50 needs a inflammatory marker at the time of consultation, and if there's a high level of suspicion, you put them on steroids. And clearly papilledema will be a red flag. We're worried about raised intracranial pressure, and increasingly we're worried about this condition called idiopathic intracranial hypertension, often seen, not often seen, but predominantly seen in young obese females. So that's why fundoscopy is so important. But one of the problems with primary care is every 5 careers or so, something will come along and you hope that you've got it in the back of your mind and those neurons will fire. You've got to think about things like carbon monoxide poisoning. You've got to think about things like malignant hypertension. You excluded that with blood pressure and other serious things like meningitis, encephalitis, hopefully you will not overlook. So those are your red flags. Having excluded a red flag, you can now consider an orange flag. And the main thing here, or an orange button, the main thing here to worry about is a tumor. And Alok has been through all this, and here is some of the data from primary care. So against a background of approximately 1 in 10,000 adults in the population getting a tumor, when you come and see your GP with a headache, you've got about a 9 in 10,000 chance. If you're under 18, that goes down by a factor of 3. If you're over 50, it goes up by a factor of 3. And there are some of the figures for the other settings. Alex alluded to some of these, so I'm not going to go into them. This is over 1%. This is a red flag. So these people will need investigation. But I think from our perspective in primary care, it's the orange flags that are most problematic. And here the risk of an underlying problem is 0.1 to 1%. And here they all are mainly related to raised intracranial pressure. But there are some difficulties. Headache with a significant change in character, unless you're into headache and you've got to feel for it and feel for patterns, it's difficult to say what a significant change might be. But I think from our perspective, the one that's from this case, the one that's important is that if a primary headache diagnosis has not emerged in an isolated headache after 8 weeks, that is an orange flag. There's one other orange button, and that's cluster headache. Cluster headache is arguably the most painful condition known to medicine. This is a picture of someone who's shot himself with a shotgun pellet. Cluster headache with a shotgun pellets in his skull. Suicide headache. It took about 16 to 20 years to make a diagnosis. It's now down to probably just about 3. But it's really important not to miss that and don't mess around with it. I think that's an orange button, and you can't really miss cluster headache if you know what to look out for. It's this agitation, it is high impact, it's periorbital unilateral, and it has autonomic features. So those are your orange and red buttons. If you can reassure yourself in that first 10-minute consultation, you cannot worry about orange or red. You can then go on to press a green button, and you give the person with headache a diary, and you ask them to go away and see them again in 4 weeks. But if anything, obviously tells them if anything gets worse or if anything changes, come back sooner. Diaries are interesting things. A lot of people put a lot of emphasis on diaries. I tend not to find them useful. And here you're using them as a delaying tactic while you're allowing a pattern to emerge. So they come back at 4 weeks. Has a diagnosis emerged yet? You know, so you increased your level of neurological examination, and Alok alluded to this really useful examination by Giles Ellerington. Just Google Giles Ellerington 3-minute neurological examination, which is very useful. You do some routine bloods, not that these are going to be remotely helpful. Okay, you might pick up a abnormal liver function test to allude to secondary and unknown secondary deposits, or you might pick up an unknown renal failure. But these are, again, a delaying tactic. Everyone feels reassured by having some blood tests taken. It's highly unlikely they're going to be helpful, but I think that's another delaying tactic. Continue the diary, go away and see me again in another 4 weeks' time, please. If anything changes, get back sooner. So they come back at 8 weeks. You repeat your 3-minute examination. And I think an important point is you don't do any further blood tests looking for antiphospholipids or LE or SLE unless there's a clinical indication or a significant past history. So no more blood tests. And at 8 weeks, you discuss imaging. And Alok mentioned this problem of incidental abnormalities. I use a rate of 10%. And I think that's a useful rate to discuss the anxiety that occurs quite frequently with people who have normal brain scans with abnormalities that are incidental. And NICE is very sure on the fact that you do not image for reassurance alone. I think this problem about to scan or not to scan will be reasonably short-lived. There's a number of interesting blood tests that are coming up for brain tumor. I think within the next 3 to 5 years, we will be seeing blood tests for tumor. There's one interesting study that's looking at fundoscopy by an optician combined with looking for subtle changes in the frontal lobe. Can you name 15 animals in 1 minute? And if you get past both those tests, you're fairly okay. But they haven't published that yet, but that looks like a quite interesting short way that you might like to think about whether a tumor is present. Okay, so that's very quickly our first case. What about our second case? This is a complex case. Stabbing at times, you think, what on earth's going on here? All the psychosocial stuff going on, pains all over in the neck, not sleeping, depression. Oh, by the way, I want to scan it as my friend had a brain tumor. How are you going to cope with this in 10 minutes? Well, clearly, you're going to have to take this in a number of bites. Here's our management approach, which is very different. And I think this is really important. You are not going to cure these people and you tell them that. You're aiming to shift their locus of control. And I think this is a really important concept. These people are out of control with their headache and all their other problems. And you're aiming to shift the locus so they have control and understanding over their problem rather than the converse. You need to witness their predicament, understand their story. That's incredibly important. So many people at our clinic tell us no one's ever sat down and take me seriously and listened to me before. That is hugely moving, hugely important. Take them seriously, witness their suffering. And then you must offer them a coherent story. We all like a story. We like to make sense of the world and meaning in terms of a story. And you have to offer them then a coherent story of what's going on. And those are really important 3 basic management approaches to this complex case. So how are we going to do that in 10 minutes? So in the first 10 minutes, you're going to ask them what the impact is. You're going to take an interest and get a feeling of how this is impacting on their life. You're going to exclude medication overuse headache. 99.9% of these people will be chronic migraine with medication overuse headache. You're going to reassure them, re-scan. You're going to look in their eyes, reassure them, re-scan, and then you're going to take a diary, ask them to take a diary, go away and come back and see you in 4 weeks' time. You're going to tell them there's no cure, but the aim of our management is to take control here, and you take them seriously and you understand their problem. So that's you're off to a really good start. So they come back to see you for the second 10 minutes. You're going to start unpacking the headache, as Mark alluded to. Often people get stabbing pains here, they get dull pains here, they get neck pains there. Go for each, ask them to describe each one at a time. If you ask them how many types of headaches they get, they will always be able to say they get 3 or 4. Get them to describe each one at any one time. One of those phenotypes will almost certainly be migraine. And if one is migraine, all the rest will be a migraines type process. So you unpack the headache, which almost certainly will be migraine. You reassure them again about a scan. You start them on some treatment, and you again ask to see them in another 3 to 4 weeks' time. This is when you can explore and explain the comorbidities. This is really important. All this, the pains all over will be probably fibromyalgia. They probably have IBS. They might have restless legs, so they're not sleeping. Their neck and shoulder pain, they almost certainly spend a fortune on chiropractors and osteopaths. Neck and shoulder pain is prevalent in virtually all our patients that we see in our headache clinic have neck pain. It's nothing to do with the neck at all. C2, C3 originate in the cervicotrigeminal complex, which is the origin of the migraine generator. So most of this neck pain, well, in fact, all this neck pain I think we see in people with migraine is low-grade migraine. So you explore and explain comorbidities, you focus on their anxiety and depression and sleep, and you start beginning to offer them a coherent story. And then you follow them up. So that's very, very quickly a complex case and how you might start picking that up in 10-minute intervals. And if things are not moving forward, then you refer to a headache specialist if not progressing. And I would, no disrespect to my neurology colleagues, I would try avoid a general neurologist, but look for a neurologist with an interest in headache or a GP with a special interest in headache, because I think you need to be involved in headache and start unpacking these difficult, complex cases. So I'd like to leave you with a quote from the ancient Greeks: cure sometimes, treat often, comfort always. You can always do something to help anyone with headache. Just a note on our headache clinic in Exeter, just Google Exeter Headache Clinic. We've got huge numbers of management plans, videos for patients, doctors, patient information sheets. There's virtually everything there, so you might like to have a look at that. So that's hopefully given you some pointers to when the next person comes in with headache, you can survive perhaps a little bit better.
You're on mute, Fayaz.
Oh, I beg your pardon. Can you hear me now? Right, so we are on the gallery view. So everybody, right, There are a few questions that I answered as we went along, and there were a few questions that I wanted to take live. Let's start with a question to Alok. Somebody, Janet Dorr, asked the question, what features would make you think of cerebral venous sinus thrombosis?
Yeah, I mean, that's a good question because, and I'll give an interesting anecdote. So, you know, the way the sort of coding system works, sorry, I'll answer the question, just give me a minute. The coding system works is that when patients are admitted to hospitals, certainly in Scotland, is that, you know, there's an inputting diagnosis. And we looked at this. So we looked at the coding from the Scottish government, and when you looked at from Greater Glasgow and Clyde, in 1 year, there were 5,000 patients who were coded as having cerebral venous sinus thrombosis. Whereas actually, when you look at neuroradiology, it was just 40. So that's a hugely important question that, you know, what are the features that you should think of venous sinus thrombosis? The first one would be a past history of any thrombotic tendency. Anybody who has a history of DVT or pulmonary embolus, I think, and I think one of these slides, the nice slides, has that as one of the predisposing conditions for a secondary headache. The second is that the vast majority of patients who have cerebral venous sinus thrombosis have a focal neurological symptom or sign. Quite often it can be a seizure. Sometimes you have, you know, a hemiparesis or focal sensory symptoms in addition to the headache. You can have thunderclap headache as an isolated presentation of venous sinus thrombosis, but that is rare, certainly rarer than the presentation of headache, but with almost always having some focal neurology. Bear in mind also the predisposition, and of course, if you see a pregnant patient with new onset headache, then absolutely that's something you think of.
Thanks, Alok. The other question is to Mark. How do you avoid cognitive bias in your daily practice when you're taking a headache history?
Probably very badly. I mean, I think I mention it because I think we've all made a sort of series of quite similar points about what is common. And it's really helpful to understand that, because I think it's I think if you understand, like David says, that people with tension headaches really very rarely seek medical attention for those, and therefore it's probably not tension headaches, it's probably migraine. And if you understand that actually, the majority of patients who present to A&E, it's still primary headache, they're still primary headache disorders. That's really helpful, because actually you're going to get things right a lot of the time. The problem is with that is you start seeing migraine everywhere, and I think I think that sort of just that advice to stop and think, even within that really quick consultation, just to have that 2 seconds at the end where you just go, okay, was there anything that was odd there? Was there anything that didn't fit? I think that's the best way of doing it. Just to question yourself and have just when just as you finish and as you sum up and you get in your own mind and you're almost that point where you're just about to go, okay, well look, this is what we're going to do. That's a good point. Just to have that 2 seconds, just to stop and think and just question yourself before you go on. I mean, we're all, all the evidence is that we are inherently prone to these cognitive biases, but it's really useful to understand that we are, and that, that helps us avoid them. So that 1 second stop and think.
Well, I think we are all victims of pattern recognition, and the more senior you get, the more you cut corners, and you're bound to make mistake. And if you don't make mistake, you don't see enough patients.
Well, I think the other thing, I think that the thing is that if you don't, you cannot make mistakes, but then if you don't, you're probably not going to make diagnoses. And I think that's, and again, I think that's a really important thing is, I appreciate, I think David's, advice to use the most powerful tool that GPs have is time, and that ability to to allow things to, to emerge and evolve. And that's a huge, I mean, we're so discouraged in secondary care to follow up patients and see them again. And, those of us who do then get into, all sorts of trouble, for doing it, and, huge clinics and all the rest of it. But it's so valuable. But also, it allows us, it encourages us to then, even if we can't do it first time, to make a diagnosis. And that's so important in this whole process.
Thanks, Mark. This question came from Iran by Dr. Ali Gubevi. So the next question has come from Ali Asar. I'll put it to David. In primary care, obviously, you see quite a lot of migraine. The question asked is, what's the relationship between migraine and period? And I suppose that he's asking about menstrual migraines.
Yes, as I alluded to, there's lots of migraineurs don't like things that change. Everyone's looking for this elusive trigger all their lives. And okay, there's clearly lots of triggers out there. But if it's not obvious, I tend people not to worry too much about triggers, but realize that things that change often cause problems. So it's changes in stress levels, changes in hydration, changes in food, changes in estrogen levels. So when you're getting the drop with menstruation of estrogen, that can often trigger a migraine or actually make migraine worse. And I think it's, as I alluded to, it's worth being aware of that. Because perimenopausally, if you've got a marked estrogen sensitivity, you're going to get into even more trouble with your migraine. So it's worth being aware of that. Was that the question?
I think the bottom line is why it is so common in women, and I think you mentioned about estrogen and the hormones, things like that. But I think it's a totally separate topic, and we'll have Shazia Afridi sometime in the next few months to talk about women and migraine. Okay, thanks, David. So the next question, coming back again to Mark, somebody asked, I mean, it's not related to the topic today, but I think it's an interesting question. How effective are these new CGRP monoclonal antibody for hemiplegic migraine?
I mean, I think that it's a really good question. I mean, I think most people, I would regard hemiplegic migraine as simply a variant of migraine with aura. It's these are except with the possible exception of the patients who sort of the rare patients who have definitive channelopathies and the sort of familial hemiplegic migraine conditions, but certainly the sort of sporadic hemiplegic migraine patients, I would regard that as just a particularly specific variant of migraine with aura. And all the evidence suggests that the CGRP monoclonal antibodies work for all forms of migraine, including menstrual migraine, including migraine with aura and without aura, and chronic migraine. So, I mean, I've got a few patients who have hemiplegic migraine that have found CGRP monoclonal antibodies helpful, and I would expect that we would find them as helpful as we do in other forms of migraine.
Thanks, Mark. Alok, there is a question which I'm just reading live from the screen. What are the some tips on under or over investigating when you're doing neurology or headache medicine as a telemedicine in this current pandemic?
Yeah. I think that's a great question. I think, and I think that's one that we are all, in a way, struggle with. I have to say that because telemedicine, the one big, and I know David mentioned about the use or not of examination, but what telemedicine doesn't allow you to do is examine the backs of the eyes, which are a hugely important part of assessment. And I think it gets back to the history. It gets back to how much what you're getting from in terms of red flags. And I think that if you are concerned with regards the features you're getting on the history, if it's a thunderclap headache, the patient goes into a hospital for assessment. But if it's a progressive headache and you are getting that history, one of the things which I use and I have used perhaps more during the pandemic is to ask if the patients have attended their opticians, because a lot of the optician services have reopened, and I think that gives us some assessment of fundi, and you can base your threshold for investigating based on that. But you know, I would lay as much stress on the history as I've always done. If I'm concerned about somebody's examining that I need to examine them, then I would rearrange an appointment and see them and examine them and see if they have attended the optician for a fundus assessment. So I don't think that, I mean, the answer I suppose is that I don't think it changes my threshold for investigation. So I'm not over investigating patients in this difficult time.
Faiz, I wonder if I could I just interject there? Can I ask the three of you, when was the last time you saw someone when your examination changed your management plan?
Mine, never.
Not uncommon, David. You know, I think that for example, you know, I think Mark touched on the. Sorry if I can answer. Mark touched on the hemiplegic migraine. In my experience, hemiplegic migraine is, you know, is one of the most you know, one of the diagnoses that is almost always incorrect, because it's almost always a migraine with aura, and the examination of the individual, you know, does help in a significant manner to be able to say, well, are these episodes, is your symptom related to hemiplegic migraine or not? And I think also the attendance in secondary care when patients attend A&Es or acute medicine, examination does have a significant role. That's what I would think.
Well, I think we are seeing a lot of headache and epilepsy are the easiest to do in telemedicine. So Mark, you tell us whether it has ever changed.
Well, no, I mean, I think my answer to David's question is actually quite a lot, but not generally specifically neurological abnormalities, but more sort of musculoskeletal. I think a lot of neck, you know, I think that you know, a lot of patients probably do have musculoskeletal and you know, sort of neck issues, which probably do feed into that tendency to headaches and drive primary headache disorders. And examination, I think, is quite useful from that point of view. But I know I agree. I very rarely pick up, you know, my trust have made us put a note on the end of all our letters saying that you know, that they're telephone based, and therefore any incidental findings that might be picked up haven't been picked up. And I very rarely have picked up incidental findings that have sort of suddenly changed the way I've managed things. I would say, however, that I did last week to scan somebody's brain for what turned out to be carpal tunnel syndrome. So you know, it's not, you know, it is. I think the problem with telemedicine is that you know, I think Faiz is right. I think for epilepsy and headache disorders, it's actually so much of it depends on the history that it probably doesn't make so much of a difference. I think for in other areas of neurology, yeah. I think we're probably there is a tendency to over-investigate people or over-scan people because we're not in a position to examine, if we're not in a position to examine them easily and quickly.
Correct. Well, let's take the last two questions. David, some words about vestibular migraine. The question is, how do you, any tips on the history when somebody has dizziness and headache?
Yeah, it's a really interesting question, actually. And International Headache Society has got a fairly formal criteria for this, which I think is changing. I think anyone that gets migraine, but also gets vertigo, not just during the migraine phase, but in between migraine attacks, I think you must seriously consider a migrainous process. And I suspect what's happening, we don't really understand what's going on here, but I suspect what's happening is just as migraineurs tend to have increased sensitivity to light and sound and in between attacks, I think they get increased sensitivity to movement as well. So I think vestibular migraine is shifting, our thoughts and our diagnosis criteria are shifting. And I think I'll have a very high level of suspicion, having excluded all the other common things in primary care with someone comes in with dizziness. If they have migraine, I'd treat, there's no evidence base here whatsoever. We don't understand anything about the pathogenesis. But I'll have a very low threshold for treating an associated dizzy problem or vertiginous problem in a migraineur, even though it occurs between attacks with migraine preventive medication. I don't know what my colleagues feel about
that. Alok?
Yeah, no, I'd agree.
How do you diagnose retinal migraine? That's the question that has come here.
I have to take, I don't think I've ever made a diagnosis of retinal migraine, to be really honest, because I think that I don't think I've seen them. It probably does exist, but I guess it's seen by ophthalmologists. I don't recall seeing.
I mean, I think one sees cases of retinal vasospasm, it seems to me retinal migraine. This is this is a sort of whole different thing, isn't it? But to me, retinal migraine doesn't make sense, because migraine is a process that occurs within the brain stem, or cortical spreading depression on the surface of the brain, and the retina is a completely different sort of tissue. It's neither brain nor cortex, and so I don't really understand what is meant by a migrainous process affecting the retina. Just very briefly on vestibular migraine. I mean, I think migraine and dizziness is hugely common. There are some people who clearly get vertigo as a migraine aura, and that's some really interesting work that Adolfo Bronstein and Barry Siegmungle did at Charing Cross a few years ago, shows that there is a cortical representation of vestibular function, and I suspect that some people probably get vertigo as an effect of cortical spreading depression affecting that area, in the same way that people get visual and sensory disturbances, and other people just get dizzy, and in a lot of cases, if people have an underlying vestibular imbalance or mild vestibulopathy, then migraine will bring that out. So I think there's a lot of reasons for people to have vertigo and dizziness with migraine. And as you'll see, I don't really believe in retinal migraine.
Great.
No matter what.
David, your take on retinal migraine?
Yeah, I think it's illusory.
I know.
It's got into the literature, it can't get out.
There are quite a few more questions, but I think we are running out of time. I think this is why I put 15 extra minutes on the webinar. I'm glad that still nearly 200 people are still, logged on to the webinar. So can I thank all the speakers, David, Mark, Alok, to get it on a very short notice in the first webinar. I'm really grateful for all of you. And thanks to all the people who have attended. This next one is on the 24th of February, 7 p.m. And it's on secondary headache. So we're gonna cover venous sinus thrombosis, thunderclap, subarachnoid hemorrhage, and all other secondary headaches we would try to cover. So until then, see you on the 24th of February. And any concluding remarks from any of the panelists, please?
I think it's a great organization. So thanks very much, Faiz. Thanks to Bash.
I thought I would make some problem or mistake, but I think it went on quite well.
Good, yeah.
It's just my first webinar, Okay.
Yeah. No, it's great. I mean, thank you. Yes, thank you very much, Faiz, and thank you to everybody for attending and sticking with us, and we look forward to seeing you next month.
Thank you very much.
Bye-bye.